You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, this is Dr. William E. Morgan, president of Parker University, and this is Clinical Rounds. And today I have a special guest with me, our chair of chiropractic sciences, Dr. Dana Hollinsworth. Dana, thank you for joining us.
Thank you for having me.
So we've been talking a lot about the adjustment and which is really something that makes chiropractors unique,
Yep.
being able to adjust. But the concept of there's things that chiropractors need to know as spine specialists that, we can't have one size fits all. We need to attenuate our dose and what we do for various conditions. So I've kind of put this concept, and I try to conceptualize it in my head, that the science of the adjustment is really the science of the chiropractor. That it's the inclusive 8-year education that you've received, and actually you give to others, that we need to tap into as we address patients. So we talk more about the science. I'm reminded of the movie Matrix, or even Through the Looking Glass.
Yeah.
Where you get to a point where you have to choose between the red pill and the blue pill. And if you pick one pill, you go blissfully on with your life, ignorant of all new things that come out, and you practice the same way you did as when you graduated. But if you take the other pill, it means your eyes are open that actually I'm responsible to change how I practice as the science advances. And you have to keep up with this. So I think what you're trying to do in your role is to create lifelong learners. Is that right?
Oh, we hope so. That is a huge goal. Because if you stop learning today, you're going to miss out on what happens tomorrow. We don't know what that's going to be.
So we get caught up with the chiropractic lesion, the manipulative lesion, the thing that we adjust to fix.
Yep.
And what happens with that is we want to make sure we try to fit a lot of different people into our box. And what I've found is we're so x-ray centric, we look at the body as bones, forgetting that there's soft tissues in there. And the science of the adjustment is the science of the chiropractor. Is you take the patient, are they eligible for a chiropractic adjustment now, or do I need to make sure there's not something in there that would be contraindicated, or have to change my technique to a lighter technique?
We need to look at their whole person, right? And consider all the tissues, all the exam findings.
So how do you feel we're doing with that, with our educational process?
I think the education at Parker and the information the students are exposed to is incredible. It's up to them to own it, but I think we're doing a fantastic job of providing it. It's growing and changing and getting updated regularly.
So, and I'm going to put an image on the screen here. Here's a patient that I've treated. The image on the left shows a very large herniation.
It does. And
that herniation, you can see the motor changes. There's bony edema, a lot of pain in there, and bony pain. The image on the right shows that disc herniation is pretty much resolved. This is 5 months apart. So in the circles there, you can see that there's a person who had a pretty big herniation, and under chiropractic care, all of chiropractic care, that means not just the adjustment, but advice, exercise, lifestyle changes, alterations in their workload, that patient's condition's resolved. That's what I think what we really need to do, is be able to not just try to fit everybody into this, they've got a PI ileum or whatever the listing's going to be, but why is that way? Look deeper and take the entire package that you've taught them, their neuro exam. There's like this patient had sciatic neuralgia, but her neurology was intact. She had no loss of bowel or bladder control. She didn't have any motor loss. Reflexes were impaired, but who cares? But she did have nerve tension signs. So people don't operate on nerve tension signs. They shouldn't. Although you'd be pretty hard pressed to find a surgeon that wouldn't operate on this case if they had seen him. So here she is in axial images. This is slicing her axial. The image on the left shows her at first day I saw her, 5 months later, pretty much resolved.
So this was your patient, correct?
Yeah. Well, these are almost always my patients that I show. So this is a case, that it's not just the adjustment. Now at first, she had a hard time tolerating adjustments. As she progressed. Now, at the end, she still had that deep bony ache from the bony edema. You always get bony edema when there's a disc herniation or disc surgery or most other disruptions of that. Motor changes will happen. Motor changes, which is synonymous for in-plate inflammation, will happen when there's an acute Schmerl's node or any type of disruption of that soft in-plate and the bony in-plate. So, and she had that. Now here's another case where a chiropractor collaborated with a physical therapist.
Okay.
They came in with the image on the left, and she couldn't bend over. So the chiropractor thought it was stuck. He needed to adjust her into flexion. Should we always do that?
No. No, sometimes you should not.
No. And so she came in with a small herniation. So,
Yeah.
so he was adjusting her because she was stuck in that position. He palpated, motion palpated. She's stuck there, so I must be able to push her in that direction.
Yeah.
And then he collaborated with a physical therapist who put her into flexion exercises. So these
She got a lot of flexion.
Yeah, she got a lot of flexion. Too much flexion. So
Yeah.
I see her walking down the hallway in the hospital, and she's flopping her foot, and she had lost her gastroc.
Oh no.
So the image on the right shows what happened after their treatment. And I actually assumed care on her, immediately took an MRI, found that they took a small herniation and made it a big herniation. They took out an S1 nerve root. She had to get 3 surgeries, never had restoration of the gastroc. So we got to get out of our own heads.
We need to know when to not adjust, right? Yeah.
Just because we palpated this way and
Yeah.
there's lost motion doesn't mean it needs more motion.
Yeah.
Clearly you could have, through your physical examination, or their physical examination, they could have seen something's here.
I think that's the thing that students don't always understand when they're going through school and ask, why do I have to learn this? Why do I have to learn that? Because of this patient right here. Because of the patient that you need to recognize, hey, this type of adjustment is not appropriate at this time. Does it mean they're never a patient? Not necessarily. Right? So bring it all together.
All together. And here's something. If you do a trial of treatment, even if you're wrong, you do a
Right.
trial of treatment, you're doing it, they're getting worse. What
Ask
do you do?
more questions.
Stop what you're
questions.
doing.
Absolutely, right? Get another assessment, do another image, something to get more
In
information.
her case, she actually had peripheralization taking place. So even if the pain is getting better, now peripheralization versus centralization for sciatic neuralgia, if the pain's going up, even if it's getting more intense, that's a good sign. But if you're working on somebody and the pain's progressing down further the leg, especially if it goes below the knee, that's a bad sign.
Yeah, that's not good.
You've got to stop what you're doing. So
Yeah.
again, I guess I'm trying to bring out is take the whole package of the
Yes.
4 years of chiropractic education and the 4 years of undergrad, and really don't get caught up in so much in a technique or your mindset that you have to keep going down that row. If somebody's not getting better, stop what you're doing. Here's another nice image or animation here of a synovial cyst. And I've seen dozens of synovial cysts in my career. What you'll do is you'll go. It feels fixated, and so but it is your body's trying to protect the body from going in that direction. In this case, the synovial cyst is actually facing the cord, so the body does not want you to go into lesion. It will fight it, and if you force it, it will magnify the symptoms.
Not a good outcome. Yeah.
No. You don't have to have X-ray vision. If they're making them worse, you don't need to know what's making it wrong. It might be time to move them on to an MR or something else. So synovial cysts are interesting. Of course,
Spondies.
spondies, yeah. And there's, spondies are there's degenerative spondies, which
Yep.
kind of act like stenosis, and then there's isthmic spondies, and you really should, you don't treat those the same. So, and not necessarily. Some people respond to similar treatments, but we need to look deeper. And we talked. I interviewed Stu McGill last week, and his big thing is there's no such thing as non-specific back pain.
I'm looking forward to hearing that interview.
No, it's good. Well, there's always a reason.
Yeah, absolutely.
And his adage would be, what would you do for non-specific leg pain?
You need to ask more questions.
Yeah.
What's the cause?
Yeah, what's the
Yeah,
cause?
yeah.
You certainly wouldn't do the same treatment for all leg pain,
No, I hope not.
but most of the research that's done in back pain is non-specific back pain, so it has no value to us clinicians.
Yeah.
So here's one for you. What do you see here?
Well, I don't know that you should adjust this patient.
So, and this is another one of my patients. So this patient has cervical spondylotic myelopathy, and you'll see these with pre-diabetic patients, people with DISH. there's a spur large enough to hang your hat on growing inside the canal.
Yeah, it's a little dangerous.
Yeah, you don't want to adjust. Now, I will almost guarantee every chiropractor will treat these patients, you'll adjust them, and they'll feel better.
They respond well initially, huh?
Well, because the arthritic pain,
Yeah.
the joint pain will get better.
Yeah.
But because the cord doesn't feel pain, you don't realize that you're causing damage. That cervical range of motion exercises might even hurt this. So in this patient, they come in, they're clumsy, their hands, they have urinary and bowel leakage, they're bent over, their gait becomes wider, they just think they're getting older. And you go in there and they have neck pain. You adjust them, the neck feels better. And you keep doing it because the neck feels better. But the cord, which has no perception of pain, is made worse.
We have to be careful with pain, right? We can't, it's not a good indicator for progress, right?
Well, yeah.
It's not the full story.
No, so what else when they come in, and I've heard chiropractors and chiropractic students say, well, that's not chiropractic. That's some of the things we teach. And my answer is, it's all chiropractic. So this is why you teach people to do the complete examination.
You need to know what's going on with the entire person before you make a decision to adjust or not adjust. You adjust the wrong patient on the wrong day, it's not a good thing.
No, you're right. It's crazy. And there's compensation for patients. So we teach to do the complete exam on every new patient. This patient could have been in your office for 30 years. You did their exam 30 years ago or 10 years ago. You need to re-examine them.
And you need to look at a patient with fresh eyes. I think you're bringing forward a really good, real brief point of discussion here is that this patient had balance changes, they had gait changes, they had other signs that had you been seeing this patient, week after week or month after month for a long time, and you just, so-and-so is here again, sometimes you need to step back and say, who is here today? Because, and do they look different from last time? And I think we get so focused on just continuing through our day sometimes that taking that step back to take the fresh eyes is very valuable but easily lost. And I don't think it's just in chiropractic,
no.
in medicine in general.
I guarantee every medical general practitioner manages these incorrectly, watching them slowly get worse over time. And because they miss it. It's cervical spondylometrophy. We're all going to see it. But you have to go, like you say, use the mental discipline to go back. If I was seeing this patient for the first time, just because it's happened gradually over years as their patients, you miss it.
Because you know them.
Yes.
Yeah.
You're growing old together with them. So that's a good point. So I used to go around the world teaching my discourse, and I remember as I go around, I teach the detailed neuro exam, and I try to get people where they're efficient at, and I'm passing out reflex hammers. I'm seeing these doctors, and I'm telling you, a lot of them I could tell by the way they handle it, they haven't picked up a reflex hammer in years. And almost always, I would find somebody, we do the exam, I'd find motor deficit. I remember I was in the Netherlands, young doc, he'd lost his gastroc. It was gone. He didn't
wasn't
even know.
aware?
No, he compensated for it. And it was crazy. Even so it's the patient I showed earlier with the flaccid gastroc. She got into CrossFit. She was doing jumps. She was convinced she was actually compensating by using other muscles for that. But
the body's incredible. You ask it to do something, it's like you got it.
And they won't notice.
Yeah.
So that's why you need to be the person who looks and
the big picture.
And it doesn't take long, a motor exam with reflexes, dermatones, myotones, minute and a half.
Yeah.
All upper and lower extremities. If you're in practice for 5 years and can't do it in a minute and a half, you're not doing it enough. It should become second nature. In fact, I have to slow myself down and I've been out of patient care for about 7 years, but you have fever, chills, night sweats, unexplained weight, all these red flags, they should run off your tongue so readily that you have to force yourself to slow down.
So the patient can listen?
It should be that second nature, in my opinion. Oh, here we have, this is not my patient, but you look at the MRI on the left, it shows there's a lot of infolding of ligaments and touching the cord. So one of the things we teach people is to do this particular test, the Hoffman's test. So I showed you guys the images of the cervical spondylometrophy. This is why we teach it. You're going to have patients that this is positive. And how long does it take to do this where you just grab that middle finger and you flip the fingernail down, and if you get that OK sign, that means you probably have an upper motor neuron sign. You can look for hyperreflexia, you can look for clonus downstream, but just a simple test like this tells you,
It's enough to give you pause to say, maybe I should look deeper.
And what would you do next?
Yeah, it probably is some images.
Yeah, get some
Yeah,
images.
let's see what's going on.
And so something as simple as this could save someone else's lifestyle. So the biggest message I have, I think, from this thing is I want to talk a little bit about all the things we're taught, that examination, that when we first do it as students, how long did it take you to do your first full body examination in the school?
I spent 2 weeks preparing for my test over that, so I could get it all done in 45 minutes.
That's pretty amazing.
That was a lot of work, though.
It took me 3 hours plus like a 2-hour interview. But what I did was I practiced. I could, not that you should do it in 10 minutes. I could knock it all out in 10 minutes. Probably a 250-point exam. Certain things I should have slowed down with. Some things you want to cluster together, but your skills should be so good, even if you hate doing examinations, be so good at it you spend less time doing it.
Exactly.
And then the patient comes in with neurological deficit that you're working on, you don't have to do the whole exam again. Just go back and visit neurological integrity, and then also look at, basically the neurological integrity and making sure the positives are, go back to the positives, see if they're changing.
Yeah.
So
look for something outside of pain.
Yeah, don't stick with pain. I feel better. So another interesting case, and this is a patient of mine that I'd seen. He had a tethered cord. And when I was in school, this is one of those things that you can really damage somebody if you use the incorrect techniques on this. And this is important for us to talk about this one. So this person, he had played Navy football. He was an officer of the Navy. And he had headaches and neck pain. I was adjusting. We took a picture of him. We found a Chiari. Now, Chiari is where the brainstem, the cerebral tonsils herniate through the foramen magnum into C1. So it's already pulled down. One thing I've learned is when there's a Chiari, and I always do full spine MRIs.
Do you want to know what's happening on the other
Why
end?
is there Chiari?
Yeah.
And before there was MRIs, there would be tethering and they wouldn't know.
Yeah.
And somebody with a scoliosis surgery, they would correct the scoliosis and pull the brainstem down and kill the patient.
That's not good.
So these images here show the rest of the story. So this patient has a Chiari. His brainstem's going down into the foramen magnum and C1. But we also found, you see the yellow arrows, a lipoma of the filum terminalis, so it anchored the cord. And you can have tethering from meningitis, from conjoined nerve roots, from other sources. It doesn't matter where it comes from. A tethered cord should significantly change how you treat these patients. So this person, basically, like right now, if you bend your head forward, there's a range of motion to it. For him, every time he bends forward, it pulls his brain down because it's anchored. The filum terminalis is anchored. If they go in and snip it, it may now shift the cord up, and then now the nerve roots are being tractioned. So it's not an easy solution.
No.
And we shouldn't think, well, just adjust it, we'll make it better. And I've talked to people who think that. The other thing in here is the green arrows are showing the detrusor muscles, which are the muscles of the bladder. So this person had a neurogenic bladder, but his neurogenic bladder wasn't one where he lost control. It was one where he had retention. Because there's two types of neurogenic bladders. One is, it's obvious if you pee yourself, you know something's wrong. Anuria is less likely to present itself. Now, if you look at this, what do you think would happen if you did a Y-strap adjustment on this person?
Oh, that would not be a good result.
Now, Y-strap is a very rigorous, or there's a Houston chiropractor who does some very vigorous long axis distractions, which I like that adjustment for myself, a long axis distraction. For this patient, it could be devastating.
It could be
yeah.
Yeah, I'd say it would not be a good outcome, but most likely.
Yeah.
Yeah.
And what would happen?
You could pull the end of that cord.
You could pull the brain down. It's not good.
No.
So again, this person had upper motor signs.
Yeah.
Look for those signs. We teach them for a reason. They should be taught. Now, moving on to that bladder, the neuroradiologist did not mention that bladder. So that's where I've taken it upon myself to learn MRIs and being able to read every image I can. The next, we have a little video here talking a little bit about what happens with a bladder problem. Now, the bladder has two functions. It's to store urine and to void. And it's got a complex system of reflexes. But normally, the ureters bring urine down there, it's stored, and then it goes through the urethra. As the detrusor muscles contract, as the sphincters open up and allow it to go through. It's a concert. If there's a problem where those sphincters don't function properly, that's a type of it, your muscles have to contract so heavily, the detrusor muscles have to contract so heavily that they become hypertrophic. So if you see an MRI with really large muscles, it's either they could have prostate cancer, prostatitis, or a neurogenic bladder. All of those things. Anuria is a medical emergency and requiring an immediate referral to a emergency department. So we talked a lot about just cases and just looking deeper. So what advice would you give the doctor in the field who's been out for a few years and maybe forgotten some of these tests and want to know, what can I do to be an efficient doctor?
Well, that's a great question. If you don't feel, if you don't feel confident in your diagnostic abilities, I would say pull out your notes, pull out your books, do some research, freshen up on that, because you never know when learning one skill might save someone's life, and not knowing that skill may actually make a patient worse. So I think it is very important to be skilled at your diagnosis. And if you don't know, call a friend, call a doctor, call Parker, call someone and ask more questions, because ultimately we want to help our patients.
So somebody comes in with just, nondescript back pain or neck pain. Should you do upper motor signs on them?
I'm going to say yes, especially after this discussion.
I'm saying yes too. Yeah. And as I said, I've traveled around giving these lectures, and I know a lot of people have shelved the upper motor stuff.
Yeah, because they probably don't find it very often,
No.
or maybe they didn't learn to interpret it in the first place. And those things we're not good at, we don't like to practice.
And if you do it though, I guarantee every year you'll find several
something.
cases. You'll MS, you'll find tethered cord. Because these are all my patients. This isn't like pulling out of the test books. If I'm seeing them, most everybody's seeing these cases, and you're gonna something as simple as that Hoffman's test or eliciting clonus, or that's pretty hyper-reflexic.
Even if it's enough to just say, I want to ask another question. I hope I'm wrong, but I want to ask this question just to make sure you're safe. Patients respect that.
They do. So we're putting these on our CE. We're in Parker Success Academy. We've got CE classes on this. We've got Chad Cook for ortho test. We're also going to put in here some free resources with neuro exams. So
that'll be great.
Yeah.
So
Basically,
if you don't know your neuro exam, stay tuned.
Yeah,
That's what I heard.
Yeah, do a basic neuro exam, and maybe we want to have a subsequent episode where we just go over these things and how do you because it's kind of scary if you haven't been doing it for a while. Just here's how to do a 3-minute or a neuro assessment that could save a patient's life. Certainly, before you do a long axis distraction adjustment, you should better make sure they don't have an upper motor neuron lesion.
I think most adjustments can be good for most people as long as it's the right person and the right adjustment. There's some you really want to watch out for.
Well, I was adjusting that patient I showed a couple slides ago, the one with the tethered cord. He felt good with his adjustments.
Yeah.
This one right here, it felt good. Now, I wasn't doing long axis distraction on him, and that probably, and also start light, work your way up.
You can always add force. You can't take it away.
Bam. So that's one of the things I have when chiropractors adjust each other. Like if I have a new patient who's never been to a chiropractor before, I don't give them a hard adjustment. And I don't maybe adjust all the segments. I adjust them, see how they tolerate that.
Yeah.
You can add more. If you go to a chiropractor, they will always give you a hard adjustment. I mean, a chiropractor to another chiropractor.
Another chiropractor.
So say, maybe you want to take it easy on me. So anything else you'd like to discuss on this topic of basically looking a little deeper before you adjust?
I think you brought some really good awareness to people who maybe have never heard of some of these things before, or just kind of figured, I don't know why I need to do those and never find them anyway. So just bringing the awareness of your skills were not wasted. And if you have time even if you don't have time, you need to make time to relearn those skills, to be honest.
Yeah. I agree.
Yeah.
So if you don't think your patients have them because you're not looking.
Yeah, you can't find something you don't look for.
You might have gotten lucky, but one day you won't be.
Yeah.
So we're here to make better doctors, and that's why we have this series. You've been listening to Dr. Dana Hollinsworth, and I'm William Morgan, and this is Clinical Rounds.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.